My name is Lisa Zimmerman. I'm from the Rehabilitation Research and Training Institute in Albany, New York. Thank you for joining us for today's webinar, Developmental Disabilities and Geriatrics, Physical and Psychiatric Pharmacology Overview. These professional development webinars, which are presented in conjunction with RRTI and the Lewin Group for social workers, counselors, registered nurses, and other healthcare professionals, are supported through the Medicare-Medicaid Coordination Office, or MMCO, in the Centers for Medicare and Medicaid Services, or CMS, to ensure beneficiaries enrolled in Medicare and Medicaid have access to seamless, high-quality health care that includes a full range of covered services in both programs. To support providers in their efforts to deliver more integrated, coordinated care to Medicare-Medicaid enrollees, MMCO is developing technical assistance and actionable tools based on successful innovations and care models, such as this webinar series. To learn more about current efforts and resources, please visit Resources for Integrated Care at www.resourcesforintegratedcare.com for more details. Little housekeeping before we get started. Your microphones will be muted throughout the presentation. However, there will be a question and answer portion at the end of the webinar, so if you do have a question, please click the raise hand feature on your control panel at the designated time, and you'll be unmuted by an administrator. You can also type your questions into the chat window, and an administrator will ask the question out loud during that designated time. There will also be poll questions throughout this presentation. A window will appear with the questions, and you can submit your answers at that time. At the conclusion of the webinar, a tab will appear in your browser prompting you to complete the evaluation survey. It is required that you complete this evaluation survey in order to receive 3 contact hours each from Michigan Social Work Continuing Education Collaborative, New Hampshire Nurses Association, National Board for Certified Counselors, and National Association of Social Workers. If you are unable to complete the survey at the end of the webinar, you'll receive an email tomorrow with a link to complete the survey at that time if you've not already done so. So at this time, I'd like to introduce our instructor to you. Dr. Eileen Triggerboff is a clinical nurse specialist in a private psychotherapy practice in Western New York and is Director of Program Evaluation at the Buffalo Psychiatric Center in Buffalo, New York. Dr. Triggerboff has a doctorate in nursing science and is board certified in 4 areas, as well as being a national and international speaker and consultant and on a wide variety of clinical, research, and professional topics. Dr. Triggerboff is author, co-author, and contributor to 14 books and dozens of journal articles, and serves on the editorial boards of several professional journals. Dr. Triggerboff is a partner in an independent research group and provides expert testimony and reports across the country. She is active in community service venues, including clinical settings and family support groups. She also serves as a computer systems and statistical consultant and belongs to numerous professional nursing organizations. Welcome, Dr. Triggerboff.
Well, welcome. I'm glad to be here. I'm glad to be seen and heard, and then to talk about content all at the same time. A wonderful technology. So we're going to talk about developmental disabilities and geriatrics, the physical and the psychiatric pharmacology. It's just going to be an overview. There's going to be, because we have, ultimately only 3 hours to do this. Of course, we're not going to be able to cover every nook and cranny of pharmacology, but we're going to try to cover the highlights. And of course, you can load questions in, and we're going to set aside some time at the end to answer some questions. So in general today, what we're going to be covering is what we do for screening and preventative health with people who have any kind of disability and they happen to be geriatrics. We're going to review the current findings in the medical assessment of older individuals who have disabilities, and we're going to talk about how you as service providers can prepare recipients for a long and healthy life, which includes screening and having preventative health discussions, and we'll get into those details. We've chunked it out into different categories, and we're going to talk about medical updates on people who are geriatric and they have a developmental disability and they have diabetes, cardiovascular care, epilepsy, respiratory issues, medical impacts of Alzheimer's dementia, and some other dementias we're going to go into briefly. We're going to talk about some gender-related health issues that happen with people who are in the senior years, bone health, and the medical impacts of depression, which is quite common. So, yeah, we're going to chunk it out into different categories. So the first category is diabetes. So 90 to 95% of people who have diabetes have type 2 diabetes. It's has had a number of labels over the years, and people still use certain labels and other areas don't. But in general, type 2 diabetes is not related to childhood onset, although you can get type 2 diabetes as a child. The most important foci for treating type 2 diabetes are glycemic control and acknowledging the association between diabetes and vascular complications. The research has been quite robust about this for the past several years. We have far more information about the interweaving of vascular complications in diabetes. And with people who have developmental disabilities, they're at a higher risk for diabetes anyways, and we'll talk about that in a little bit. But in general, and something to keep in mind, and I believe we have a poll question about this, is that there is control of your glycemic index in less than 50% of people. And this is 50% of everybody, not just 50% of people who have a developmental disability in diabetes. Diabetes is extraordinarily hard to manage. You're dealing with personal preferences and personalities and activity levels and comorbidities. If you're sick with a sinus infection on top of having diabetes and you have a developmental disability, you're not going to be as active as you normally would be. So you're not going to be burning up as many calories, and adjusting the diet might not take that into account so quickly. So, you know, a good thing to pay attention to. There have been a number of studies done. The Accord study and the Veterans Affairs diabetes trial, the VADT trial, has brought up a fair amount of information, so I'm going to cover that kind of quickly. Looking to the future, adding glimepiride to current insulin treatment for people who are using insulin to manage their glycemic levels. That can improve the glycemic control with a significant smaller daily insulin dose. So if somebody was on a certain level of insulin, if you added glimepiride, you would be able to lower the amount of insulin they were on. And that's, you know, a pretty important discovery. Another a cluster of research that's been done on diabetes is the number of supplements that are showing some promise for type 2 diabetes. And, you know, we have to keep in mind that even though something has shown a little bit of promise, it doesn't mean it's statistically significant, and it might not work on the particular group of people we are trying to provide services for. But things to keep in mind and to track the research on, see if anything new pops up in the next year or so, is the use of vitamin C and vitamin E, to use lipoic acid, melatonin, red mold, as opposed to the other wonderful colors of mold that we are able to generate on basement walls and in Tupperware. Red mold is special. Astragalus, cassia cinnamon, and Imodin made from aloe vera and Rheum officinale. And those studies have had, you know, they're not incredibly robust studies. People use supplements in an uncontrolled manner. They'll just use it. And so we don't really have the ability to take a look at these different groups of people. Let's say we have a group who's just using melatonin, or we have a group that's just using cassia cinnamon, and comparing their improvement on their diabetes. We haven't really been able to do that in a very robust way from the research point of view. But this is what's out there in the research that can be helpful. But I wanted to put a little bit of an emphasis on Imodin. Imodin right now is just in animal study phase. It is not yet into phase 3 studies with human experimentation. But in the animal studies with the animals that have very similar metabolic processes to humans, it has lowered the body weight, which you know is extremely important, especially the weight around the middle. Weight in general can create a cardiovascular risk in general, and certainly it can bother your joints, and your back isn't going to be too happy if you're overweight. But the real risk, especially when it comes to diabetes, is the weight around the middle. You carry that weight around the middle, and it raises your risk for diabetes very high. So what they noticed with these animal studies is that the lowered body weight did focus on the weight that was around the middle, the waist of the animal. It decreased the blood glucose levels, it decreased the serum insulin levels that the body was using to metabolize the carbohydrates, and it improved the utilization of the insulin that was on board, whether it was naturally produced by the individual or introduced from the exterior. And along the way, it improved the serum lipids. And that kind of indicates to us that we are continuing to be on the right track, paying attention to cardiovascular health with the diabetes. So we have to look for human studies with amodin. But these results from the animal studies have been quite robust, and I have nitpicked at the statistics on it and just the general formation of the study. Were they well controlled? Were they well done? Were they done on a variety of different animals? And they're pretty good studies. So we'll keep an eye on that and look to the future for maybe some help in that regard. So that's diabetes. Right next to it, I'm talking about cardiovascular health because they are interwoven to a large extent. Atherosclerosis, which is the arterial wall buildup of low-density lipoproteins. I know you all know this, but I'm on a roll. So high-density lipoproteins are healthier to have in your body. They're not soft and spongy and goopy and they stick along the side of the walls. Low-density lipoproteins are sticky and they clump up and they form a real problem when you have that low-density spongy matter along the inside of your vessels, your blood vessels. Inflammatory disease, an important thing to pay attention to, and check the markers. And the most reasonable markers to pay attention to with this population of people we provide services to are the high-sensitivity C-reactive proteins. The HS, that's the high sensitivity, and the CRPs are C-reactive proteins. But also the lipoprotein-associated phospholipases, the A2s. They're very important to keep an eye on. And let me see if there was anything I was going to say about that in particular. Good study. Just came out in 2014 in the journal Inflammation. Always good to pay attention to that. The elevated markers, so let's say that your A2s or your CRPs are elevated, what can you do about it? So you have some people who you're service providing, you're paying attention to their diabetes, you're paying attention to their atherosclerosis or just their general cardiovascular risk. What can you do to help? Weight loss, especially weight around the middle. And that's a difficult process for us. You know, you've all worked with people who have developmental disabilities. You know that food is extremely important, and it is an unusual problem to have when someone has an eating disorder. They're eating too much, they're eating too many carbs, they're eating too many problematic things for their metabolism to be able to handle. But you do need a certain amount of food. So it's not like you can tell somebody stop doing that. And telling somebody, anybody, not just somebody who has a developmental disability, you really shouldn't have that much of that, is difficult. So weight loss in general is something that you have to be on all the time in as many ways as possible. And one of the things that I have found helpful with people who really do need to lose a little bit of weight, we're not going to try to do the whole thing all at once. It's overwhelming. It's overwhelming for the care providers as well as for the individual, is just to look in the short run. What are we going to try to do today about food? So an easy way to pay attention to what are we going to do today about how much food you're going to take is take a look at portion control. Portion control has been extraordinarily helpful, at least in my practice, to help remind people how much they should have. So, for example, pasta, spaghetti. If you're going to have any kind of macaroni or spaghetti, an adult normal serving size of spaghetti, pasta, whatever you call it, needs to fit inside a baseball. You go to an Italian restaurant or a restaurant that specializes in some kind of pasta dishes, they're going to give you a plate that has 9 baseballs worth of macaroni on it. And people will eat half of it and they feel virtuous. It's not good enough because you're still having 4.5 servings of pasta. And it's really going to be a problem for your cardiac health because you're not going to lose weight. You're eating too much of that. And people will say, well, gee, if I don't eat that, if I just eat a baseball's worth of volume of pasta, I'm going to be hungry. Well, that's not all you're going to eat. You're going to have a vegetable, you're going to have a salad, you're going to drink some water. Water is very helpful. So there's other things that the person should be ingesting, and they should have like a color palette. But the serving size of the things that really need to be taken into account for cardiac health are the things that need to be driven home. Just last week I was helping somebody. They were going to be going on a medicine that routinely adds a few pounds. It's just a side effect of the medication. So before putting them on the medication, we talked about, all right, what can you do to prevent or minimize the weight gain? Because you really can't stand to lose any more, to gain any more weight. And so we went to the supermarket, and I said, all right, you're going to make submarine sandwiches for supper. Let's go get the ingredients. So he went and he got a submarine roll, and he got some cold cuts and lettuce, tomato, onion. And so we talked about making a submarine sandwich. I said, all right, how much of this submarine sandwich should you have for dinner tonight? It's an adult male. And he said, well, I'll have half of it because that would be healthier for me. And when you look at the package, at least on the submarine sandwich roll that he got, it serves 9. Who's going to cut a submarine into ninths and eat 1/9 of a submarine sandwich? It's unrealistic. So there have to be a lot of tricks and tools and a lot of help from nutritionists. We need a full treatment team on this to help people lose weight. It's not as easy as just, you should drop a few pounds. Whole grain enriched hypocaloric diets. There are many different strategies to do low caloric diets, hypocaloric. And people can get into fads and they can get into some interesting conundrums about that. But in general, you should have about 10 calories for every pound of ideal weight you want to be. So if you want to be 100 pounds, and it has to be reasonable. If you're 5'8", you're never going to be 100 pounds unless you really have something else going on wrong with you. But if you weigh 100 pounds, then you should have about 1,000 calories a day. That doesn't mean you can only eat 1,000 calories, but it means that between all of your activity, which burns off a certain level of calories, you can have a certain amount of food in. If you weigh 180 pounds and that's your ideal weight, then you can have 1,800 calories. So that's a general rule for men and women. It needs to be, probably need a nutritionist to make it perfectly accurate. So by hypocaloric, you're not supposed to be starving yourself. A starvation diet never works because sooner or later the person has got to eat. And as soon as they eat, their body's going to hold on to every calorie because our bodies sometimes are smarter than our brains. And it says, gee, I just went through a starvation episode. I better hang on to all these calories and not let them go because I don't know when I'm going to get another meal. Harkening back to 25,000 years ago when our bodies were really like looking for food and it was a chance encounter that you'd be able to get something. So hypocaloric is basically, for our modern purposes, probably less than you're eating now, but not a ridiculously low amount. Statins are very good at lowering your lipid level, of course. There are other options to statins. You don't have to use a statin. Like, for example, Questrin is not a statin. It's a powder that you mix in water. Don't ever mix the Questrin in with, like, soda. It'll just make this 9th grade volcano science project out of your liquid there. It just bubbles all over the place. It's not a statin. So there's another way to do it. Basically, it just binds up your bile so that your body is fooled into thinking that you're not ingesting so many fats. Niacin and omega-3 fatty acids, when added to a statin, most of the research is fairly consistent now that says that omega-3 fatty acids, you just take an omega-3, it's really not going to do much for your hyperlipidemia. It's not going to lower your lipid level. And years ago, that was the story. Gee, maybe that's all we need to do, have some fish or have some omega-3 fatty acids. But now we know that what's really helpful is adding it to a statin if you really want to have the full benefit. And I have a picture of some chocolate on the slide. Not that I have that listed here, but just some new research that is coming up right now, and it's nowhere near finished, is they're taking some of the cocoa flavonols and they're looking to see if it can help with hyperlipidemia and increase the cardiovascular health quotient that you can get from that particular dietary factor. However, you'd have to eat about 26,000 candy bars in order to get the benefits, the flavonols that you would get from the capsules that they're using in this research. And if you ate 26,000 candy bars, I pretty much can guarantee that your cardiovascular health would not be tip-top. So this research is working with 26,000 men and women, and it's a government-controlled study. It just started in mid-March, so we're going to be tracking that very carefully. And in general, when we're looking at something that's going to lower these elevated markers that indicate cardiovascular illness, weight loss, whole grain enriched hypocaloric diets, and statins. Those are really the things that can help those elevated markers be reduced. The risk of cardiovascular disease, it really fluctuates with, if you have a fluctuating blood pressure increase, that increases your risk for cardiovascular disease. For example, if somebody has high blood pressure and it's being treated, but it's not a very consistent and reliable treatment, it keeps them stable for a little bit, and then it'll go up, but it won't go up a lot, and then it'll go down as they adjust the medication. And that fluctuating blood pressure actually is a higher risk for cardiovascular disease. And it used to be that we thought, well, gee, at least it's managed some of the time. And it turns out that we really need to be on top of that. We need to watch what's going on with their adherence. Is there non-adherence to antihypertensives? I can't even count the number of people who say to me, I didn't take my water pill, because that's one of the ways that they are controlling their blood pressure is by reducing the volume in their cardiovascular system. And they didn't take it because they were going to be going to the dollar store and the bathroom isn't very convenient, or they were going to be going to Denny's and it's always such a problem to get in there. And so whenever they're going to be active and out in the community, which is what we really want people to do, they're not managing their hypertension. So that fluctuating blood pressure, because they're not taking their antihypertensives the way they should, is putting people at higher risk. So there needs to be some pretty frank discussions about this and manage what's going on with people's activities so that they're comfortable at all times around their elimination and the management of their hypertension. And hypertension is associated with poorer cognitive functioning, not because when people can't problem solve very well, or they're not thinking very clearly, or they even have a dementing process like Alzheimer's or any of the other 14 dementing processes. That's not, they're somehow making their blood pressure go up. It's just associated. Every time somebody has a dementing process, most of the time from Alzheimer's, or they have poor cognitive functioning, you really need to look for hypertension. And if they haven't been screened for hypertension, now's the time to do it. So an update on cardiac medications, and I'm sure most of you know this, is if you have emergency cardiac situation, the abbreviation for the medications that we give for an emergency is MONA, and that stands for morphine, oxygen, nitroglycerin, and aspirin. Those are the 4 medications that we use in these emergency situations, but this is not the order that they're in. The order that the MONA is in is really oxygen first. If you have access to oxygen and somebody is having a cardiac event, that's what you get into them first. The next thing is nitroglycerin. You get a nitro tab under their tongue right away. Then you give them aspirin, and at the very end of the line you give them morphine. But ANAM isn't as easy to remember as MONA. So the first thing you do is get some oxygen, and if you have access to it, great, but sometimes you won't. Nitroglycerin, aspirin, morphine. So let's talk about beta blockers. I know people know a great deal about beta blockers, either used alone or as a second-line therapy with antihypertensives, because they do reduce high blood pressure situations. There are thiazides, there are calcium channel blockers. It doesn't really matter which it is. Beta blockers is a fairly large category. It's commonly used to reduce stroke risk and cardiovascular disease. And most of the time what you have to do, and this is not just for people who have developmental disabilities, although it is worse with people who have developmental disabilities, is that you must combine two differently acting drugs to get the results that you're looking for. So you might have a beta blocker, and you might have something else that goes in a different category. So let's talk about what some of those would be. Metoprolol and some other beta blockers, their job in managing hypertension is to dilate vascular structures. So you have your arteries and veins, and they're at a certain width. You want to make it a little wider because it'll lower the blood pressure, because there's more space for the blood. So it's not pushing through at a really high volume. That reduces the blood pressure. But you have to watch for hypotension. So when you open up these vascular structures, what can happen is that the blood pressure can just drop. And hypotension is a real risk. So whenever we're treating hypertension, that's something we have to watch for. And people respond very differently to their medications. So we usually go very slowly and very cautiously. And knowing that we might have to use 2 different agents or 3 or 4 different agents to get their blood pressure down, we don't want to really confuse the picture and have too many things starting at once or too many things changing at the same time. So you add a beta blocker and you watch for hypotension. They don't have a hypotensive result, that's good. But keep in mind that respiratory tissue, all down your trachea and in your bronchioles and your lungs itself, there are beta receptors. So if you have beta blockers that you're giving, those beta receptors, those special receptors that take that molecule, and you're blocking it, you could make somebody who has any kind of a respiratory illness sicker. So if they have emphysema, if they have asthma, you've got to watch for that with beta blockers. It might do a beautiful job on the blood pressure management, but in the same time it might be making their asthma or their emphysema worse. Nothing's more distressing than not being able to breathe comfortably. So that's a trade-off. And you say, well, okay, can't use beta blockers with that person, or we can't use that level of dose. So that has to be kept in mind. Very, very, we use a lot of beta blockers, so sometimes that needs to be paid extra special attention to. Recognizing when somebody is having heart failure. Symptom recognition is really not the best with people who have developmental disabilities, not because they're not paying attention, but because neurologically they do not have a robust interoception. Interoception is the ability to know what's going on with your body, where you're tracking what's going on with you. And interoception, it varies. Some people have very low interoception. Some people are way too into their symptoms and what's going on. But everybody has a continuum in there. The people who have developmental disabilities tend to be at the lower end of interoception. So they might not know when they're starting to get a cold, when their nose is running, or they've sneezed a bunch of times. They might not occur to them to say, oh, I wonder if I'm getting a cold. Because their interoception, their cognitions about their own symptom level is, and the stimuli they receive from their own neurological symptoms might be impaired or deficient in a number of ways. And we already know that hearing and vision loss is already common in people who have developmental disabilities, and sometimes recognizing heart failure comes with a vision change or a hearing change. And if they already have those problems in place, you might not notice a difference. Because the interoception is not robust, they might not attend to those internal symptoms as well. So nurses in particular, but everybody, needs to be able to teach symptom awareness and teach it and teach it and teach it so that it becomes a little bit more natural for people to pay attention to how they're doing. Cardiac disease and diabetes. Putting them both together is not an accident. It's very, very common that somebody who is developmentally disabled is also going to have diabetes, and they're also going to have cardiac problems. The research disputes the benefit of certain current guidelines, and There's going to be a lot of discussion about this. There should be a lot of discussion about this. But right now we're on the cusp of making some changes. We've been doing something for quite a long time, and it's been researched, and the outcomes are not ideal. They're not even approaching what we would want them to be. So those kinds of changes need to be kept in mind. Right now, aspirin might not be all that useful for reducing cardiovascular disease risks when the person already has diabetes. A spectacular study just came out last year. They looked at a number of different kinds of diabetes in males and females, different 8 cohorts of age groups. And when you have diabetes, giving that person aspirin prophylactically or subsequent to some cardiovascular event is really not helping with reducing their cardiovascular disease risk at all. It's like hardly noticeable. The benefit for women was absolutely zero, and the benefit for men was so mild that it really brought into question whether it was worth it because of the bleeding risk, especially people with diabetes and developmental disabilities, because the people with developmental disabilities will have a slightly different GI system. They're wired a little different. They have far more gastrointestinal problems than people who don't have developmental disabilities. And when you give people aspirin, even low doses, it can increase their risk for bleeds. So if you have only a mild benefit in men, and I tell you it was really pretty low, and absolutely zero benefit for women, you have to take into account, gee, what am I doing here? So you have to take bleeding into account and symptom awareness, and signs and symptoms, of course, should be monitored on a regular basis. Comorbidity, being sick with more than one thing at the same time with a poorly controlled diabetic individual. Anti-angina drug, ranolazine, it lowers the glucose, but it doesn't cause hypoglycemia. And I know a lot of clinicians have been very concerned about the kind of medication that you're giving for glucose control, but the angina is what's really the problem. So you want to give a medication for angina. Somebody has these kind of painful processes, and you don't want their glucose to go so low that they're hypoglycemic and therefore not having a reasonable amount of glucose in their system so that they can manage, so that they can think and they can perform basic functions. So just keep in mind the ranolazine is good for lowering the glucose, but it doesn't just drop it right down. So that's a very helpful thing if somebody also has angina. So that's the diabetes and cardiovascular aspect. We're going to go on to dealing with managing seizures, managing epilepsy, because it is such a common diagnostic group for people who have developmental disabilities. So, as you know, there are different types of seizures. There are partial seizures, generalized absence, atypical absence myoclonic, and atonic seizures, which are different. And then we have the unclassified seizures, which basically means, I don't know what kind of seizure that is. Partial seizures, when you look at EEGs, there are discrete areas in the cerebral cortex of the brain that show this distortion in electrical conductivity. And the partial seizures, you can really see it. Generalized seizures, when you do an EEG on somebody, there's this diffuse region. It's all over the brain. You can't poke at one particular area and say, that's it, that's where we're going to target our attention. So partial versus generalized also means that it's going to change what's going on with the medications. Partial seizure medications, more than half of people, 58% of people who have any kind of seizure disorder, whether they have a developmental disability or not, do not achieve seizure control with the current anti-epileptic drugs, the AEDs. The side effect profiles are quite notable. Dizziness, somnolence, sedation. It affects about 97% of people who take these medications. So while we do have some anti-epileptic drugs, some AEDs that are a little activating, for the most part they're sedating or they change the perception of what's going on around the individual. We'll talk about that in a minute. And of course, adherence issues contribute. The biggest problem with anti-epileptic medications is timing. People need to take their medication at the same time every day. It doesn't matter if someone's coming to visit, or they're going on a picnic, or it's raining really hard, or there's a blizzard, or there's a power outage. Doesn't make a difference. The best adherence protocol is to go with the timing first. People who don't take their meds at the same time every day are extraordinarily difficult to manage, and that's usually what counts for it's not working. The med isn't working. And it's not really, I don't have clear evidence that the medication is not working if the person hasn't given it a good run of 4, 5, 6 weeks of taking it every single day at a particular time of day, and there's no variation. So the biggest issue is timing. So just a couple of things that have come out recently. The FDA just put out a warning about Lamictal, which is an anti-epileptic drug, but we also use it for mood stabilization, and aseptic meningitis. This is a meningitis. It's a lining of the brain, the meningeal lining, and it inflames, but it's aseptic. It means it's not an infectious process. It's a swelling process. So the person is going to have a really bad headache, and they're going to have fever, and they're going to have chills from the fever. They might be nauseous. They might vomit. Their neck is usually pretty stiff, and that's a classic symptom of meningitis in general, is a stiff neck. But they're going to be sensitive to light and be photophobic to a certain extent. So it's happened a number of times, enough for them to put out a warning about, if somebody's on Lamictal, they've been taking it for a while, and now there's this particular problem going on. They have a stiff neck and they kind of feverish. That's something to take a look at, the aseptic meningitis. So let's talk about treatment options for people who have these kinds of seizure disorders and medications are not working. And they've tried to do the schedule piece, a very important focus on the schedule, and it's not working. So if meds aren't going to work, then you think about surgery, which is a very frightening process. There are some special diet options. There's some complementary alternative therapies, and of course there's the vagus nerve stimulation, which is also a surgical process. If you pay attention to the older medications, just to harken back to the first bullet there, older medications that are used to treat seizures usually require blood monitoring, and in my experience people don't really like to have their blood drawn on a regular basis, so they might be on these medications where blood monitoring would be very helpful. I'd like to know, are they at a therapeutic blood level, are they taking it, but they don't want to have their blood drawn, so you're working blind, and that's a problem. But if they're on the newer medications, the newer anti-epileptic drugs don't usually require blood monitoring. Sometimes you might want to get a level just to see where they're at. But people who have developmental disabilities metabolize medications a little bit differently because of those gastrointestinal issues I mentioned before. So you might not have the same number on your lab results that you would get from people who don't have a developmental disability who are taking the same medication at the same dose. Pay attention to polypharmacy. This is where medication reconciliation comes into effect. When people are taking medications for seizures, sometimes, especially if they're living with family members or they live in an area where their supervision for medications is much more slowed down, that the person is given more and more information and independence about their medication. What I've noticed is a lot of polypharmacy. Recently had somebody who had a whole shopping bag full of pills, and sometimes she took some of them and sometimes she took other of them, depending on which bottles she pulled out of the bag that day. So she was certainly taking her medication, and she was doing it at the same time every single day because I asked. But the old medications, as they shifted dose or as they changed to another compound, weren't being disposed of. So she had a lot of very confusing medications going on, and polypharmacy was the problem. So when you're looking at whether medications are working or not, of course you have to look at the schedule, but also look and see if they're taking some old stuff that you thought was discarded or pulled off the regimen, and they were supposed to be using a new set of medications or a new set of doses. Just to overview the medications and to parenthetically comment on what they're generally used for. First-line medications for seizure control is usually valproic acid for all types of seizures. That's usually right up there. Depakote. The Depakote also has a nice feature of it can be mood stabilizing to a certain extent. But if the person did not have an unstable mood, if their mood was fairly stabilized, and you put them on any of the mood stabilizing anti-epileptic drugs, but in particular Depakote or valproic acid, the generic kind, you take the risk of destabilizing their mood. And it can be temporary. It doesn't have to be that all of a sudden they're having some kind of a mood problem. But it's something to pay attention to. When dosage change or you're adding another medication and it has a mood stabilizing feature to it, something just to pay attention to so you don't have to call in a consult if you don't need to. You say, oh, gee, look, that their mood is, they're a little too hypomanic, and they're maybe even a little manic-y, or their mood is a little depressed, and I'm wondering what's going on with that person. If they just switch meds or the dose just changed, that might be all that's going on. Also, valproic acid is very good for treating migraines, and about 40% of people who have bipolar disorder also have pretty severe migraines. So if you have somebody who has a seizure disorder and they're bipolar and they have migraines, then you might just have to take one med. But the side effects are something that need to be dealt with. Lamotrigine, we give that for generalized, atypical, and atonic seizures. We don't usually give it for partial seizures, but some people are very individualized in how they respond to medications, and it might work. It's not like you're never going to see it. Topiramate, Topamax, generalized, atypical, and atonic seizures as well. Carbamazepine, Tegretol, partial seizures. Something that is quite common, well, I think it's common, with people who are taking carbamazepine is that the risk of a rash is about 12%. So if you have somebody who's taking carbamazepine, Tegretol, for seizure disorder or for mood stabilization, that's something to take a look at first. If they have a rash, you're going to be looking at their food, you're going to be looking at their detergent, you're going to be looking at a number of different things, but also take a look at their meds. Phenytoin is used for partial, it's Dilantin. We don't use that at all for mood stabilization. It has absolutely no impact on mood. Oxcarbazepine and ethosuximide, both for either partial or absence seizures, not used quite as often. We always have to keep in mind that just like blood pressure, seizure disorders sometimes require a medication to be approaching the problem from a different pathway. So we have to have alternatives if somebody's had difficult side effects or if they just need another medication to help. All of these medications will be able to provide some relief. And clonazepam, that's Klonopin, it's an anti-anxiety agent. It's not specific for seizure control, but sometimes it can help because as a tranquilizer, it can decrease some of the electrical conductivity in the brain. That's why it calms people down. And so Klonopin can be quite useful in that way. Pregabalin, where's that? Pregabalin. Oh, there it is, third from the bottom on the right-hand side. That's Lyrica. Number of problems with Lyrica. It can be extraordinarily useful for seizure control, but also people are using it for pain management if they have diabetic neuropathy, migraines, certain neurological or muscular pain issues. You might put somebody on Lyrica, but also Lyrica can be destabilizing of the mood. It can make people very irritable. It can give them a hypomanic, irritable, kind of aggressive tone to them. And if you can hang on for 3 or 4 weeks with it, it might dissipate, but it might not. There's something to keep in mind. Gabapentin, which is on the bottom on the left-hand side, that's Neurontin. It's an anti-epileptic drug, but it also is used for pain management. So if I had somebody on 1,200 milligrams for seizure control, but they had a pain problem, they might need to take 2,400 milligrams a day for pain management. It's very sedating. It's a side effect. And its interesting feature about pain management is not that it takes the pain away. It takes away, it minimizes and alters the perception of the pain. So how it's been described to me is that people will feel the pain, but they don't care so much, or it's over there, or it's not really bothering them so much, and they're able to perform their duties and move along with life. So when you're talking about seizure control and you want to have some treatment effectiveness and you want to keep that in mind, it's complicated by these issues of medication absorption because most of anti-epileptic drugs are absorbed through the gut, and people who have developmental disabilities have gastrointestinal problems. They'll have diarrhea, they'll have constipation, they'll have GERD, they'll have gastroesophageal reflux disease. And for those who don't know, I just love explaining this, your stomach has got acid in it, but the acid is supposed to be pooled at the bottom of the stomach, and the stomach is right here. And there's a sphincter at the bottom that separates the stomach from the small intestine, and there's a sphincter at the top, which is called the cardiac sphincter just because it's on the same level as the heart. It really doesn't have anything to do with the heart. And sometimes with people who have developmental disabilities, and anybody who's got GERD, is that sphincter at the top of the stomach, the cardiac sphincter, is not nice and tight. It doesn't close. And so it's a little floppy, which wouldn't be a problem except people who have gastroesophageal reflux disease create a little bit too much acid, or the acid is moving around and it shoots up past that cardiac sphincter. And then the acid lays on top of the cardiac sphincter, and it's acid. Your esophagus does not like acid. It's supposed to stay in the stomach. So that acid, it burns, and that's why they call it heartburn, because it's on the level of the heart, it's on the cardiac sphincter, and that's very tender tissue, that mucous membrane there, and it can eat away at it, so it's really a problem. And you can't make the sphincter tighter, you just can't do that. So you have to find a number of ways of either reducing the amount of acid that's built up in the stomach or reducing the reflux itself, the tendency for the acid to shoot up and go into the esophagus and hurt the bottom part of your esophagus and the upper area of the cardiac sphincter. So lots of gastrointestinal problems with people who have developmental disabilities, which also means that the medication absorption is going to be different, which also means that they might not get very effective seizure control because their medications are not being absorbed as well. But you also need to keep in mind that some things can definitely interfere with the absorption of medication and the access that your body has to that medication. How is it being absorbed? How is it being distributed through the body and being metabolized? If the person is taking something to coat their stomach because they're having some stomach trouble, well, and it's coating it. So the medication is trying to get past that coating to be absorbed into the system, and it can't because the coating is very effective. So you have to time when things are being given, and when certain medication is being given, and certain helpful things like a coating medication is being given. Most of the time, the effective treatment of seizures is through using 2 or more anti-epileptic drugs simultaneously. So they're using different pathways, and you're approaching the problem in the most comprehensive way. But if the person is inconsistently reporting what's going on, so you have a consumer who's taking their medication, and they'll tell you, well, everything's fine. And they're not really paying attention, and it might be because they have poor interoception. They don't really know about their internal perception of symptoms, or they're just not able to report things very well. And we depend on a good report to know if somebody's seizures, especially their partial seizures, are being responsive to the medication we're giving. So a huge problem in seizure management is the inconsistent verbal reports from a consumer. That probably can go right up there with bad timing. So what that means for us as clinicians is we know people who have developmental disabilities can have very poor interoception. We know that for a fact. We have to gauge how much of a problem is it going to be with our individual recipients of our care, and then clinical observation, very important. What do we see? What are we watching in terms of their behavior, and what lab testing can we use to help us out? Can we get a blood level? That might help us out to determine if the medication is being taken or if it's being absorbed. So seizure management in elderly people who have developmental disabilities relies both on behavioral observations and lab testing. That's the best way to get that taken care of. And I think that leaves us away from seizure management. So let's go into respiratory health. People who have developmental disabilities have more than typical problems with their respiratory tract. They have a lot of respiratory infections, and they have a lot of respiratory difficulties. That can be because of the way they're built, because they might have problems with their bones, with the way they're shaped. They might have decreased lung expansion, so it makes them more prone to respiratory problems. They're very vulnerable at any age, but it increases with age. So whatever they had in their 30s, by the time they hit their 50s or 60s, which is considered geriatrics for people who have developmental disabilities, then you're going to expect more respiratory health issues. Something that's fairly new, and we knew it's been building up for years, is the cases of tuberculosis, especially multi-drug resistant strains lately. And because people who have developmental disabilities are so much more vulnerable to respiratory problems, putting them in situations where they're going to be exposed to people who are not very healthy. And tuberculosis in general is on the increase in the general population. So it's certainly an issue that we need to pay attention to with people who have developmental disabilities and respiratory health problems. You know, tuberculosis kills more than 1.5 million people every year. That's a tremendous amount of danger from tuberculosis, and it just didn't used to be that way. In the 80s and 90s, we didn't have these kinds of problems, but now, you know, the past 20 years, it's been ramping up, and it's become far more prevalent, and the drug resistance of it is difficult. So there's some research that's being done now. Well, one of them is going to be starting human trials in 2015. One of them is just starting its human trials this month. And there's 2 different drugs they're looking at to address tuberculosis. And it's cheap. It doesn't cost a lot, which will be good, because a lot of the new drugs are very expensive. But they think it'll be a very formidable weapon against the drug-resistant strains of tuberculosis. So something to keep in mind. Both of the drugs, they just have letters and numbers associated with them now. But there's a chemical component to both of them. They're very different. And they're both approaching this problem with something to know that we have some hope. So if you're exposed to a great deal of tuberculosis in your population, know that in the next few years we could be seeing some help about these multi-drug resistant strains. Let's see. That's it for respiratory. Let's talk about dementia. Dementia is a group of syndromes. There are a number of different kinds of dementias. Some of them are reversible, some of them are not reversible. So the reason we're making a huge deal about it is because people who have developmental disabilities have far more cases of dementia. So this is a very disturbing photograph of what a healthy brain looks like on CAT scan, and this is the severe level of Alzheimer's dementia. Sometimes Alzheimer's dementia is abbreviated as AD, and sometimes it's abbreviated as DAT, dementia of the Alzheimer's type. They're interchangeable terms, but you can see how much of the brain is just not there anymore. There's a real degradation in the way the brain tissue is composed when you have a dementing process like Alzheimer's. But all the dementias are a little different. Alzheimer's dementia and Down syndrome are both occurring on the 21st chromosome. They're genetic mutations. So that tells us not only are they closely related because they're on the exact same chromosome, but there is such a high probability that somebody who has Down syndrome will develop Alzheimer's or Alzheimer's-like dementia after the age of 50. The rate of Alzheimer's in people who have Down syndrome it's incredibly high. It's the highest of the group. It is something that you might not necessarily see behaviorally. The person might be functioning beautifully, and then on autopsy we see that they had Alzheimer's dementia, which I find really interesting. So, and I don't really have an explanation for that now, but stay tuned. So hopefully something will come along. Possibly, let's see, there's a question about this, and I wanted to, there's a poll question about it, and I wanted to make sure I talked about it. When people who, when people have a dementing process, their dementias are easily differentiated. We can tell when there's a cognition program going on. There's the person has their developmental disability with whatever level they were or were not able to accomplish in terms of their cognitive tasks, and there's what's happening with the dementia. And we're able to track that. So it's not such a mystery. If somebody has dementia, we're going to be able to see it. And in general, when somebody has a dementing process, or if they're geriatric, or if they have a developmental disability, everybody's behavior is functioning in response to rewards. There are influences that can be made. So when we talk about treating dementia, whether we're treating it pharmacologically or non-pharmacologically, keep in mind that people can respond to rewards and reinforcement and reminders, and sometimes people will respond to verbal interventions and sometimes they won't, but the likelihood is there. And also people who have developmental disabilities are going to have a recognizable dementing process much more than the general population. And you know how much it's happening in the general population. So reversible dementias, these are things that we can do something about. So it's good to track the symptomatology. And all it means is that it's caused by another medical condition, or there's an underlying medical condition that's creating this dementing process, but it can be treated successfully, and we can go and do something about that. Now, there is a difference between dementia and delirium. Delirium is 100% curable. You catch it early, and delirium is going to work for you. You're going to make it go away. Delirium is something that can happen after a major physiologic event. And if you catch it early, you can track the physiological event, correct it, and you're done. A dementing process is different. Reversible dementias, something we have to pay attention to. So here are some of the examples of what could cause a reversible dementia. If somebody has an infection, and it doesn't matter where the infection is. People who have developmental disabilities tend to have a lot of urinary tract infections. They might not come out on a lab slip as having a positive culture for a urinary tract infection, a UTI. But what's happened many times in my practice and many of my colleagues I've talked to, is that you might have somebody who has a high risk for urinary tract infections. They've had dozens and dozens over the years, and treated many times with them. And they're having a little bit of symptomatology, but not a lot. And you do a urinalysis on them, and it doesn't come out as positive. Keep in mind that people with developmental disabilities do not have to have full colonization in order to be responding to an infectious process. They don't have to have so many bacteria going on that it would show up in a lab test. They can have an unusually high level, but still a normal, what's in the range of normal for a bacterial count, and it won't show up on a lab test, but it's still, you know that person is sensitive to that particular bacterial level. So any infection can create a dementing process. Depression can certainly cause a dementing process, or it can look like dementia. And there are some ways to differentiate between dementia and depression. The cognitive degradation that happens with depression is remarkably different. Normal pressure hydrocephalus, that maybe if somebody had a shunt, it might get clogged, especially because what it's draining is glucose, because that's what's in the brain, and glucose is sugar, and it crystallizes, and it can plug things up. So sometimes you can get a little push on it to clear it out, but sometimes the pipe needs to be replaced, the tubing has to be replaced. Any head trauma can cause a dementing process. Certain drugs can have side effects that look like they're dementing. Thyroid problems, and a lot of people with developmental disabilities will have hypothyroidism, but it might be subclinical. They won't have the thickening of the skin. They won't have difficulties with other problems that are obvious with thyroid. As a matter of fact, it might look more like depression than anything with the thyroid, but it can interfere with their cognitions. Needs to be looked at. They can ingest a toxic substance, and toxicity for people who have developmental disabilities who are on a lot of other medications is a wide open field. Some medications inhibit an enzyme in our livers that help to scrub medication out, and it's called cytochrome P450. It's a great name, but basically the job of this particular enzyme is to take that stuff that you have in your system and metabolize it and get it out of you. But some of the medications that people take will suppress that cytochrome P450. So someone might put something into their body, but that enzyme that's supposed to take it out of there is being suppressed and it's not working. And it can have a toxic effect on their bodies. So things that you would not normally consider toxic are going to become toxic because of the other things that are going on in that person's metabolism. So it's important to pay attention to what the toxic effects of anything is. And then a vitamin B12 deficiency, fairly easy to detect, get a level, and fairly easy to fix, give them some vitamin B12. But as people get older, they're not going to be able to absorb and metabolize their B12 from their diet. So vitamin B12 is something that we pull in from the food that we eat, but as you get older, that becomes a much less efficient system. And when you have a less efficient system, you're going to have to supplement. So you might have to do vitamin B12 from the outside as opposed to trying to do the diet. So let's talk about how we're going to reduce the risk of dementia, because there are some options for doing that. Dementia risk is higher in those who have hypertension. So if the blood pressure can be managed, if it can be controlled, then you're going to decrease the risk of dementia down the line. And hypertension in general is very dangerous for the body, not just in cardiovascular risk, although that is certainly a major feature of it. You have an issue of blood going through the tube of your vessels at a very high speed, like a fire hose, and it's pushing on the walls of your vessels, but it's also slamming through all of your delicate organs. So it's slamming through your kidneys, it's slamming through your brain, it's slamming through your eyes. All of these high pressure issues cause a lot of damage over time, and it can wear down the walls, and that's why high blood pressure can cause strokes, because it's constantly pressing up against these vessel walls, and it weakens them, and they can just blow, and the person has a stroke. So we know that high blood pressure also increases problems that people have with dementia. So we can reduce the risk of dementia down in the future if their hypertension is managed now. They might not have symptoms of hypertension, they don't have headaches. Hypertension is a very sneaky disorder, but you've got to be on it every single day. Recent research demonstrates that there is a real value to hypertensives, any class, regardless of how it works, in reducing the dementia risk. It's good, robust research with statistically significant results. A number of different agents didn't even make a difference what class it was. This is a slide that shows the microscopic, the little red dots are the Golgi structures, and Golgi is a structure that when you have Alzheimer's dementia, it breaks that up, breaks that structure up. And when you fragment it in Alzheimer's, that's what happens. It gets fragmented. You have the plaques that happen with Alzheimer's dementia, and you also have these Golgi structures that are just being busted up. And it kills the cells when the Golgi structures are not intact. The cell dies, and the cell can't transmit messages. So you want to make sure that you have the Golgi structures protected as much as possible. So there's research in that. They're talking about doing genetic medication modification. That's kind of new. But we know that the Golgi structures are more important than we previously thought they were. So I would bet that there's going to be some medications that are going to address preventing the fragmentation of the Golgi structure so that you don't have so much cell death. So that'll come down the line. They don't know why this fragmentation occurs, but now that they've identified it as a process, they'll probably get on, I'm saying they because I'm not doing this research, they're going to track this and then try to address it with a medication that'll slow down the process. These are some irreversible dementias. Alzheimer's is irreversible, but there are lots of other irreversible dementias. Vascular dementia, so if somebody's had a stroke, or if somebody has high blood pressure that has caused a lot of vascular damage, and they have leakages, or they have aneurysms in their brain, or even aneurysms in their abdomen, can influence the dementing process. There's a difficult dementia to treat. It's a mixed vascular and Alzheimer's dementia. It's not reversible. Lewy body dementia. 10 years ago, people really didn't know much about Lewy body dementias, but now we know a fair bit more. We still need a lot more information about it. But in general, if somebody has Lewy body dementia, and you're like, well, how do you know if you have Lewy body as opposed to Alzheimer's? If you give them a medication that's supposed to calm them down and slow the aggression, like you give them Respiratory, or you give them Zyprexa or Seroquel, or any antipsychotic medication that's supposed to help them think a little bit more clearly and not be as agitated, and they get way worse, it's a technical term, then it's probably Lewy body. And that's a problem because you don't have as much medication to address these kinds of behavioral problems when you have Lewy body. The same thing with Parkinson's dementia. Medications tend not to make it better. Medications can actually make it worse. Pick's disease is irreversible. Creutzfeldt-Jakob dementia, it's like mad cow disease for people. Huntington's chorea, the chorea is talking about the neurologically impacted movements because it's chorionic in nature, it's kind of dance-like, but what's happening with their brain is that they're becoming very demented. And Huntington's chorea is very difficult. It affects their personalities. It, of course, affects their physicality. They're not as mobile as they would normally be, and they're usually bedridden, and they have a lot of problems with yelling and being interpersonally difficult, and Huntington's chorea is a tough process. And then Wernicke-Korsakoff syndrome, usually a consequence of alcoholism. The Alzheimer's dementia diagnostic criteria, people have asked a lot about this, so I wanted to make this as clear as possible. Alzheimer's, it accounts for about 70% of dementing processes, so you're pretty much going to nail it if you think that somebody who has dementia has Alzheimer's dementia. But there are some criteria that have to be met. You need memory impairment. The memory has to be impaired in a certain way, long-term, short-term, more short-term, difficult to create a new memory. And so you have memory impairment and aphasia, which is, you have to have one of those three that are bulleted on the right-hand side, at least one. But you just need one in order to make the original diagnostics stick. Aphasia is either expressive aphasia, where they're not saying the right words, they can't say the word, or they do a word mix or a label mix, like they'll call their daughter their mother, or they get the labels mixed up for things, and that's an expressive aphasia. There's also a receptive aphasia, where they just don't understand what's being said to them. It might be very clearly saying, this is what I want you to do, you know, shake hands with me. And they just don't understand. It sounds like gibberish to them. So that's a receptive aphasia. That's one a little bit tougher to pick up on. Apraxia is the inability to perform like a purposeful movement. You're going to go do something. You're going to pick something up and you're going to put it down. You can't do that. That's apraxia. Apraxia is movement with a purpose, and when we put A in front of something, it means it's not there. So that person is not able to do a very routine kind of movement, like feed themselves, and they might poke themselves with the tines of the fork because they can't get the movement correct. So memory impairment and apraxia would be Alzheimer's dementia diagnostic criteria. Agnosia is the loss or the reduction over time to recognize something as familiar. For example, one of the first people I ever diagnosed with Alzheimer's was somebody who was standing in line in front of me to sign into a conference. And there was a clipboard, and they had a pen attached to it. You're on a string, so it doesn't walk. And he looked at this pen, and he didn't know what it was. He was, you know, he was looking at it, and you could tell this was a colleague, this is somebody who was a brilliant person, and this was the first inkling that we had that he had agnosia, that he had a dementing process going on, because he did not know this was a pen. And you might see that with people you are working with, is that they will use a pen to eat their soup with, or they take a key and they're trying to cut their meat with it. That might work. They're not using it for the proper purpose, and familiar objects is usually the first to go. Later on, the agnosia can include people. So they don't recognize their mother or father. They don't recognize a caregiver who has been with them for many years. And that agnosia can be quite distressing to everybody else. It's not distressing to the individual who has this symptom. That's one of the benefits, is that sometimes they don't know that they're slipping like that. They have to have some functional impairments. They have to slip in something that they would normally do. Their ADLs, their ability to walk, their remembering where their bedroom is, where the bathroom is, things like that. There's early onset, and there's a gradual onset, and there's a gradual course. But having said that, I have had a number of people who have ended up with an Alzheimer's dementia diagnosis that it was very abrupt. Literally overnight, this one woman who was 62, very young, by any means, and she had gone to see a movie with the people from her residence, and usually very healthy person, and the next, fine for the movie, remembered it, talked about it afterwards, was very happy about the movie. I forget what the movie was, and that's not a sign of dementia. That's just not relevant. And the next morning, we're waiting for her, and she's like 45 minutes late. She's never late. And the problem was she forgot how to tie her shoes. That overnight, and so the first assumption we all made was that she had had a stroke, because she was having some trouble talking, and she really couldn't figure out how to tie her shoes. So we worked her up for a stroke, and that is not what was going on. But it was so abrupt, and it turned out, when she did die, about 7 years later, which is not a short time given her original age with it. On autopsy, she had pretty extensive Alzheimer's dementia. So even though it's supposed to be a gradual course, somebody's going to break those rules. You have to pay attention if the dementing process is happening because of something else. Do they have an infection? Do they have a urinary tract infection? Do they have a cyst that's laying on a cranial nerve? Do they have something else going on, like are they having trouble breathing? What is happening? And if there's no other medical problem, then you can think about it as a dementing process. And it can't be a delirious process, because delirium we can resolve very quickly, and it's just not going away, then it's more likely not delirium. It can't be due to another psychiatric disorder, because dementia is a psychiatric disorder. So we can't have a delusional process that's causing them to forget things and people and how to do things, a depression that's interfering with their functioning, they just don't care and they're not doing things, or an agitation from a mood instability, which is quite common with people who have developmental disabilities, more common than in the general population, and that might interfere with their cognitive processes. So you have to make sure there's nothing else psychiatric going on. And you can have a dementing process and your behavior is just fine. So with a behavioral disturbance or without a behavioral disturbance. The observable features are a gradual decline, and, so that it'll come down in their functioning and then it'll plateau. And then it'll go down, and then it'll plateau. That's very typical. They often have periods of mood and behavior problems. They'll be very paranoid, they'll be very angry, they'll be very irritable, yelling, throwing things. Their impulsivity level really goes up. So if somebody already had an impulse problem, they're going to have more impulsive issues. They're going to lose their self-care and their ADL skills, but in the later stages, there's total dependency. They're not moving. They forget how to sit up. Literally, they forget how to swallow. They forget about their bowel and urinary eliminations, and they need total nursing care at that point. There are 3 stages to dementia, Alzheimer's dementia: early, middle, and late, imaginatively called. Early stages also include some treatable mood problems. you can give the people a mood stabilizer or an antidepressant, and that can help in the early stages. Early stages, unfortunately, is not picked up very often in the general population and in people who have developmental disabilities, because we give people some leeway. If somebody is worked very hard at learning how to do the math to balance their money, so they have a little budget going, and they've worked very hard at it, and then they just let it slide. They don't know how much money they have. You're thinking, well, they've regressed a little bit, they've had a stressor, somebody has moved into their house, or somebody has moved out of their house, or their father's been diagnosed with Parkinson's, and the mother's not sure they'll be able to take care of her. I mean, there's always an issue, and sometimes we'll just slide it off to stress, which is fine. We do that too. If you forget where your keys are, you're probably more stressed than demented. So the early stages sometimes are missed. So while there can be treatable features to the early stages, usually we don't pick up on a dementia until the middle stage. Middle stage often includes behavior problems, hallucinations. Those hallucinations are usually visual. Unusual, it would be olfactory, gustatory, or tactile. Mostly they're visual. They're seeing things that are not there. There's little boys in my bedroom at night. They're playing handball. I can't get to sleep. They're seeing things that they normally wouldn't see. It's like, oh, you know, somebody just took the head off that animal. You know, horrible things or disturbing things or annoying things. The delusions tend to be paranoid. You hid my keys, or you hid my room. You know, you moved the room. You painted it a different color, and you did that deliberately to trip me up. Because people are trying to confabulate. They're trying to make up a reason for why this is a problem. They used to be able to do these things, and now they're not. So you're probably going to pick up on the middle stages of dementia. Late stages, obvious, usually includes an inability to recognize family and caregivers and normal objects. The diagnostic process is an interview. We interview the patient, the family, the caregivers. Everybody gets interviewed. There's a psychological assessment, including memory and other intellectual functionings, like a mini mental state exam. A comprehensive physical. I want to know that it's not the thyroid. I want to know that it's not an infection someplace. That whole process has got to be checked from head to toe. And then, you know, you consider an EEG because it could be a partial seizure, or a CAT scan in some way, because if it can look like the CAT scan slide I showed you before, you're going to see some differences. Rule out thyroid problems. Go there first. That's easy to fix. Hearing and vision loss that is not associated with their normal developmental disability issues. Dehydration. Dehydration is a huge issue. People don't drink enough water. And I'm not talking about people who drink way, way, way too much. But having 12 ounces of water in a day is not enough water. And when you drink other fluids, there's other things in those fluids. Like I've had said to me many times, oh, I drink Crystal Light and that's got water in it. Yes. But what's in the Crystal Light, or what's in the iced tea, or what's in the Kool-Aid, or whatever else is in there, the coffee, the tea, all those other features in it that make it not water anymore, make a demand on your metabolism. And that demand on your metabolism uses some of the fluid, the hydrating features of the water component in there. And sometimes it just cancels it right out. Sometimes it can be even more dehydrating. Alcohol is incredibly dehydrating and doesn't have much water in it, but when you have, you know, like a scotch and soda kind of thing, that's not water. Your body is going to need a lot more water than what you put in there. And dehydration is a huge problem with people with developmental disabilities. They take a lot of medications that are anticholinergic. It dries them out. Apnea, where the person will have an interruption in their breathing. Other medical psychiatric factors. In general, you have to confirm and you have to assess the status and the pace of decline so you can get the reasonable care organized for this individual. Down syndrome and Alzheimer's dementia, like I mentioned before, very common coupling because they happen on exactly the same chromosomes. So you have a genetic disorder and also a genetic predisposition for Alzheimer's. It's more prevalent at any age. You're going to have dementia even in a very young person. And the prevalence increases with age. With the general population, it increases with age. If we all lived to 100, we'd probably all have dementia. But with people who have Alzheimer's dementia and Down syndrome, the older data from 1994 suggests that 8% of people who are 35 to 40 will have Alzheimer's dementia, and 75% of people 60 and over. That's in the general population. In people who have Down syndrome, it's much, much higher. The possible early course for Down syndrome with relatively high-functioning individuals, you're going to see irritability. You're going to see that mood instability, mood swings. They're not going to talk quite as much. Maybe it's aphasia, but maybe they're trying to figure out what's going on, something is different. So they're not going to talk quite as often. And this is not something that's just going to last a couple, 3 days. This is something that's going to be now more durable in their presentation. They're going to have more problems learning new things. Because the problem with Alzheimer's dementia, what the plaques really make a problem with, is that the old memories stay in place, but new memories cannot be formed. So if you teach them how to do something, like cook something or clean something or put something away that they didn't know before, the next day they don't know it because it's a new memory and they can't access it. It was never really put into their brain. They don't have an engram for it. And you can teach them the same thing 40, 50, 60 times. Maybe it'll start to get in there because now it's starting to become an older memory. But older memories stay intact and the new ones either don't get created or they disappear. There are behavior changes and there's memory loss, so they forget where things are and what things are used for. The initial course for Down syndrome with relatively low functioning people is that they are less sociable than they were before. There's less enjoyment for whatever they really liked. I had an individual who really liked popcorn, and she just stopped eating it. She just wasn't interested in it. The smell of making it didn't entice her, and loss of self-care skills. Even if they were very poor to begin with, there's a serious degradation in them. The intermediate course for relatively high-functioning people is, let's say they go to work, their work skills deteriorate. And it's not just a couple, 3 days of those work skills are deteriorating. They're just not doing their job. They're less able to follow instructions, so they're not doing their job. And their supervisor at work might say to them, I need you to do this. And they're just not able to because they might have a receptive aphasia going on. Their language skills are going to start to drop. They might have seizures after about 2 years after the dementia starts. It's just something to keep in mind. The mobility starts to be decreased. So you had somebody who was relatively high functioning and now they're not moving around as much. They're not walking as well. There's incontinence issues, either urine, stool, or both. Hallucinations, which tend to be visual, delusions, which tend to be paranoid or suspicious or hypervigilant. And there's weight loss. The dementing process can really change somebody's metabolism, and they're going to start dropping some weight. The possible intermediate course for Down syndrome with a relatively low-functioning individual is that their memory deficits are going to be quite remarkable. They're going to have some spatial disorientation, and what that means is they're going to start banging into things. They're going to drop things, they're going to go reach for something, and they're not going to be able to pick it up. It's going to drop. They're going to spill things, they're going to bump into doorways, they're going to have bruises, and they really need to be supervised much more than before. Their diurnal rhythms are going to change, so they're going to be sleeping in late, you can't wake them up, they're going to be very tired during the day, and you're going to be wondering, why is their clock slipping? It's because of the dementing process. Their motor and gait disturbances are going to become more remarkable, and they'll probably have a seizure disorder. Just other developmental disabilities in dementia, just to comment on the non-Down syndrome group. You have Fragile X syndrome, you've got PICS, you've got all these other dementing processes, and you have other developmental disabilities. We really don't have a lot of studies on them. I don't have anything I can refresh you on in terms of somebody on the autism spectrum who has a dementing process. There's just such a paucity of studies. So if anybody wants to do that research, that would be fabulous. Problems with psychological tests, because other developmental disabilities make it more difficult to make that assessment. And you really need a multidisciplinary assessment. We need information from everybody in order to make that determination. Managing somebody who does have Alzheimer's dementia, whether they have Down syndrome or not, it's multidisciplinary. Every dementing process requires a multidisciplinary approach. They need medication. Medication doesn't necessarily, medications do not delay or treat the illness. They might slow it down a little bit, but not for the reason that you would think. There are psychological therapies, because once people start to realize that they're losing something, they're losing a skill, it can be quite distressing. So there can be adjustment disorders in response to a dementing process. And there are very specific psychotherapies, verbal therapies, cognitive behavioral therapies that are very helpful for people who have developmental disabilities. I've had a great deal of luck with the psychological psychotherapies. And it's not just supportive psychotherapy, cognitive behavioral. Environmental changes, of course, you need to have environmental changes. Daily activities that are fairly structured and routinized, support for the caregivers. Whoever is doing the care, whether they're staff members or whether they're family members, everybody needs support around taking care of somebody who has a dementing process, because it's challenging in ways that we're not used to dealing with, and they really need a specific set of trainings and ongoing support. There's reality orientation for the person who has the dementing process, and that reality orientation has to be conducted in a particular way. Reminiscence therapy is very helpful because people who have dementing processes remember the old things. It's the new things that they have trouble holding on to. That's the problem with dementia. So reminiscence therapy gives people the opportunity to have a positive experience. Behavior therapy, of course, you're enhancing the skills that they have, you're reducing difficult behavior, and sometimes it's as simple as moving them from the flow of traffic so they're not grabbing people inappropriately. You move them in a separate way in order to reduce their difficult behavior. You know, you put them on the other side of the table. Take a look at what happens before their behavior is a problem. Look at the consequences of their behavior problem, and then nothing works better than positive reinforcement. Intentional positive reinforcement, unintentional positive reinforcement, but I also put those in there because sometimes there's unintentional positive reinforcement. If somebody's screaming as a behavioral problem and they didn't used to scream, of course staff in the area are going to go run and find out what goes on. And what this teaches the individual is, hey, I can get a lot of attention if I yell. So you are actually unintentionally positively reinforcing that bad behavior. So you need to take a look at what's going on with these reinforcements. And then always take a look at the rate of behavior. Just want to cover a couple more slides and then we'll take a break. Sensory processing loss. We know that people who have developmental disabilities have sensory processing issues and sensory integration issues. But the loss in confabulation, the confabulation is where you make something up to fill in the blanks. I like to check confabulation rates by, if I'm called in to consult with somebody I've never met before, and I walk in and say, it's so nice to see you again, it's been a while. And they say, oh yeah, it's great to see you. They don't know me. So they're confabulating, they're filling in the blanks because they don't want to feel bad about it. So you're going to check their hearing, their vision. What are they seeing? When they look in the mirror, do they see when they were 8 years old, or are they seeing themselves now? Or do they see themselves now and say, who is that old man? Are they smelling what's appropriate? Some of the research on olfactory competence is you can tell somebody has a dementing process if they cannot detect the smell of bananas, cinnamon, and something else. There were 3 things. And I'm going to forget because, you know, I'm busy. Tasting, what are they tasting, or is there been some distortion in their taste, and how are they feeling? Are they able to sensorily process what's happening with them, with their 5 senses? And where are their memory gaps? Are there memory gaps from things that are long ago, or are there memory gaps from things yesterday or the day before? So let's take a 10-minute break and come back and we'll finish up.